Bluetooth mode.
So, good evening, everyone. Welcome to the first webinar in the series of webinars planned from KNA this year. We have planned around 8 to 9 webinars going forward till our KNA Con, which is to be held next year in 2024 at Tumkur. I would now like to invite our president, Dr. Sriram Krishna Arur from Shivamogga, to give his opening remark. Sir. So you need to unmute, sir.
Am I audible now?
Yes,
yeah.
Yes, sir.
Yeah. Welcome all the friends. From this year, we thought we will have a monthly webinar from different places in the Karnataka, so that we have an interaction with all the people, as well as we can update our knowledge as well. So we plan to have a monthly meeting on every Wednesday between 8 to 9:30 p.m. third Wednesday of every month. So this is the first one we are having today, being presented by Bangalore neurologist. So I welcome you all for this program. I request all the members of KNA to make available during this time and attend the program in large numbers, so that it will be a stimulus for us to organize and go ahead with the activity.
Thank you, sir. So we have 4 interesting cases from 4 different institutes. Dr. Sriram Krishna is joined by Dr. Anita Madhavan from NIMHANS as a co-chairman. I would now request Dr. Anita to start the proceedings with the case from NIMHANS.
Thank you, sir, and thank you, Dr. Guru. We are really looking forward to this exciting series. And I think it's a refreshing change that normally pathology is the last stop. So it's really nice to be the opening batsman. I would request Dr. Yasha to take over, introduce the speakers, and present the case. It's a pleasure to invite Dr. Yasha.
Hello, good evening, everyone. And without any further delay, I request Dr. Reema, who is our DM resident, to present the case, followed by Dr. Rashmi, who will present the electron microscopic features. And I thank the clinician who has provided this case. He's from JIPMER, physician from JIPMER. So over to you, Reema. You can start the case.
Thank you, ma'am. Is my screen visible?
Yes, Reema. You're audible and the screen is up.
Okay. Good evening to all. Today, we'll be presenting a case titled Muscle Puzzle in this webinar. And this is about a 50-year-old male who presented with progressive generalized muscle weakness for past 6 months. And this muscle weakness is insidious in onset and it progressed from proximal to distal. The patient also had a diplopia and deviation of angle of mouth for 45 days and dysphagia for the last 10 days. He is a known case of HIV on regular treatment for the last 20 years. He had no history of fever or altered bowel habits. Due to the progressive muscle weakness, the patient was evaluated and found to have anti-Jo1 and anti-KU antibodies positive. So he was diagnosed as a case of inflammatory myopathy and started on steroids. In spite of the treatment, the patient had worsening of symptoms and hence in spite of the treatment, the patient had worsening of symptoms and hence further investigations were done. The serum investigations are as follows. The CD4 count of the patient is 94. The HIV viral load is less than 66.9. The toxoplasma IgG and IgM are negative. Leishmania is negative. Serum galactomannan is positive. and CSF examination is inconclusive for any particular etiology, and the nerve conduction study shows predominant motor neuropathy of both upper and lower limb. Since the serum investigations didn't give a clue about the diagnosis, muscle MRI was done, which shows diffuse myositis in bilateral gluteus, quadriceps, femoris, sartorius, gracilis, gastrocnemius, and soleus. So the differentials that were considered in the imaging were a parasitic myositis, an antisynthetase syndrome myositis, and an ART-induced myositis. Finally, a muscle biopsy was planned for this patient, and a left vastus lateralis muscle biopsy was done. And in the subsequent slides, we will see what the muscle biopsy shows. So here, the bigger picture which you are seeing here is the muscle biopsy from the patient, and the smaller picture you are seeing at the corner is that of a normal muscle. Here you can see a single muscle vesicle within which you can see several myofibers. The nuclei is almost inconspicuous or not visible in this part. Comparing this with that of the patient, you can see though the vesicular architecture is preserved, there are a lot of busyness happening in this biopsy. And another striking feature is you can't see any blue tinge in this normal biopsy. Here that there are a lot of blue cells roaming here and there. So the blue represents the nuclei in the hematoxyl and an eosin stain. And in the arrow indicates few intact muscle fibers which are seen scattered throughout the biopsy. So in this bar, we can make out that something is happening within the muscle. So what it is? We'll move on to the higher power. Here we can see these clusters, aggregates, or we can also call these small masses of these round structures which are clumped together. And if you focus on these structures and try to look at the surrounding muscle fibers, you can see that the similar structures were also seen within the muscle fibers also. And the interstitium is showing some minimal inflammation composed of lymphocytes and few plasma cells. In this picture, you can see a longitudinally cut muscle fiber. But this is not a normal muscle fiber. This is a totally destructed muscle fibers. And what is causing the destruction is the within the muscle fiber, there are these large aggregates of these round spore-like structures. This is totally destroying the muscle fiber. And the muscle fiber is also bloated up, as you can see in this picture. The another important finding in this picture is these spherical round spore-like structures are in turn divided into tiny compartments by a thin septae. Though it is not clear in this power, we can very well appreciate this thin septae going in between and separating it into tiny compartments. And these are the adjacent muscle fibers showing those similar structures. And this is a higher power to show you the membranes. So here you can see those round to oval spherical spore-like structures resembling infective organisms. And these are surrounded by intense eosinophilic membranes. And these are called, since it is around the spores enclosing it, these are called as the pansporoblastic vacuoles. And this muscle fiber is studded with these pansporoblastic vacuoles, and these vacuoles vary in sizes, and the number of spores within each of these vesicles also vary. Here you can see a muscle fiber. How did we identify that this is a muscle fiber? Is because of the striations which we can see here, and this muscle fiber is almost entirely replaced by a large vacuole which is studded by these spores. And this is the highest magnification of the spore to look at the morphology. So these spores are oval to some are spherical in shape. It ranges from 1 to 4 microns, and there is no difference, not much of difference in the size as well as the shape of the spores. And there is no budding forms or no hyphal forms identified in this part. And we went ahead with the special stains. The first stain is the GMS stain. Here we can see the muscle fiber which are studded with these spores, and this is a higher power to show the intense peripheral rim which is seen in the GMS stain. And next is the PAS stain, and here you can see those vesicles, that pansporoblastic vacuoles are distinctly highlighted by this PAS stain. And the more classic feature is seen here. Here you can see a single spore, and at the end of the spore, you can see an intense PAS staining, which is called as the polar granule, which is very characteristic for these organisms. This picture also shows a nice pansporoblastic vacuole. This is also called as sporophorus vesicle. This is the gram stain, and these organisms are gram positive, which is very well seen in this picture. So the histological diagnosis, so taken into consideration the morphology and the presence of the sporophorus vesicle and the the polar granules in the PAS stain, we made a diagnosis of microsporidial myositis in this case. A few points about microsporidial myositis. It is an unicellular obligate intracellular organism, and it ranges from 1 to 4 microns. The microsporidia rarely infect humans unless the subject is immunocompromised. So the most common manifestation in humans, as we all know, it is the diarrhea, which is prevalent in 30 to 70% of the HIV patients. So how does the transmission happen? The microsporidia is ubiquitous in nature. It can be seen in all vertebrates and invertebrates. So unless the host is immunocompromised, there is no chance for disease manifestation. So the infective or the phase is the environmental phase. So the mode of transmission occurs most commonly through the undercooked or uncooked meat, through which the spores enter into our body. And from these spores, the sporoplasm is injected into the host cells, and from then the proliferative phase starts, and then these spores are transformed into merons, and this process is called as the merogony. So merons are formed by binary division, or multiple divisions can also happen, depends on the species. Once the merogony is completed, the merons will accumulate a thick membrane around it, and it will enter into the sporogony. And in the sporogony, as the name suggests, spores will be developed, but the stages are from the merozoon, sporoblast will be developed, and from the sporoblast, multiple spores will be developed. And this thick membrane, which we can see around, is what we are seeing in the HNE as the pansporoblastic membrane around the spores. And here you can see the disease spectrum. The microsporidia can cause in immunocompromised individuals. Though there are more than 1,500 species identified in microsporidia, some of the species have a common site of infection. For example, if you take the encephalitozone, it is common in the small intestine, and the patients can present with diarrhea, intestinal perforation, cholangitis, and nephritis. Similarly, there are few species which are specific for muscle. For example, Lietospora, which is common site of infection, is in the muscle, and the disease manifestation is the myositis. And there are other species such as Trachypleitospora and Anacilea algerae. So these are the species which have an affinity towards the muscle. So we also should know about the other infectious organism which can cause myositis in HIV patient. As we saw the microsporidia in this case, there is a trichinella species also which can cause trichinosis, but in the histology we can see the larval forms encysted within the muscle, and that's how we will differentiate. And a Toxoplasma gondii, though there is a size overlap between these organisms and microsporidia, the bradyzoids will usually form encysted structures within the muscle fibers, and there will be absence of pan-sporocytophorous vacuoles as well as the pronol granule, which we saw in the PAS state. The other close DD is a histoplasma. Though histoplasma causing myositis is very rare in case of HIV patient, and by histology we can differentiate it by usually the histoplasma will be seen within the macrophages, as we can see it here, and there will be budding yeast forms as well as the absence of the vacuoles as well as the polar granule. The candida, which again cause myositis, though rare in HIV patients, usually have a dense neutrophilic tissue response, and you can see the fungal yeast forms as well as the pseudohyphae. So these are the other infectious organisms which can cause myositis in HIV patient. So there are 5 important microsporidium genera that will cause myositis. The first one is the Platysphora. The second one is the Trachyplatysphora, followed by Brachyula vesicularum, Ancalia algieriae, and Tubulinosima. So among these, the top 2 are the most commonly reported microsporidial organisms responsible for myositis. When we hear the word microsporidia, our mind always links it to the intestine. So we have to remember that it is not always a gut feeling, and the microsporidia can also cause infections in other organs. So the histological clues which helped us to clinch the diagnosis in this case is the groups or clusters of spores surrounded by the pansporoblastic membranes, which we saw in the H&D stain, and the polar granules in the PAS stain. And one should always keep in mind that when we see we encounter an ovoid and refractile spores of 1 to 4 microns within the myofibers in an immunocompromised patient, we should raise a suspicion of microsporidiasis. The histological examination is crucial in making a diagnosis of microsporidia, especially in a place where it is resource limited and electron microscopic findings are not available. However, the confirmation and the species identification will be done by the electron microscopy. Now, I'll hand it over to Dr. Rashmi to discuss the electron microscopic findings.
Thank you, Dr. Rima. You've already solved half the puzzle. So let's look at what electron microscopy has to give us. So basically, when we look for a microsporidium under electron microscope, we need to look for these features. One is to look for the number of coils of the polar tubules, the number of nuclei, size, shape, the features of their developmental life cycle, and the presence of the sporophorous vesicle. So on your right, you can see this is a diagram of the internal structure of the microsporidium. So electron microscopy can help you look at the internal structures or the subcellular structures of a given sample. So this is the diagram of the internal structure, wherein this is the posterior end, this is the anterior end, and this is the posterior end. The spore is covered by a very electron dense, thick exospore, followed by an electron lucent endospore, and then the plasma membrane. Internal structures consist of the lamellar polaroplast, the tubular polaroplast, the polar tubule, which is also in the coil form, and the nucleus. This picture is showing a binucleate structure, and there is the presence of these polar vacuoles. In addition, they also have the ribosomes, which are they are supercoiled, and they're present within the matrix or the sporoplasm. So let's look into the features that we saw Basically, when we process sample for electron microscopy, they are finally embedded in a resin. So this is a resin section that is stained with toluidine blue stain. What we are seeing is portion of the muscle, wherein you are seeing this is one muscle fiber, this is another muscle fiber, and surrounding that are few blood vessels. So if we focus on these, you can see that there are plenty of spores within the sarcoplasm of the muscle fiber. So on the right picture shows that there are plenty of these porophorous vesicles which contain numerous spores within them. So there are spores also that were seen in the interstitium. Now let's go into the ultrastructures. So what did we see? We saw that there are spores within the sporophorous vacuoles, sporophorous vesicles, and this is how it appears on electron microscopy. This is just the image of single muscle fiber, which has numerous spores in them. So the next, what we are seeing here is, I'm trying to show the sporophorous vesicle that is indicated by the arrow. So this is numerous pores within the muscle fiber, which are in various stages of the development. Again, another image to show the numerous pores. Now, as I told, initially I had shown you the diagram. So we can see that the exospore, which is slightly wavy, and it is also called rugose, and which is one of the characteristic feature of a Trachypleostophora species. Now we can also see these chloroplasts. We can see the ribosomes tightly coiled, and these are the polar tubules. So we can also see the nucleus. Now to concentrate, as I clearly told, we should see at the nucleus the number of polar tubules, the shape, the size. So let's look at these features. The size of these pores were around 2.5 to 3 μmeters in the, on the long axis, and on the short axis it was around 2 μmeters. So, and each of these pores had, these are the polar tubules. The arrangement of these polar tubules is anisophilar, which means that there are two diameters of the polar tubules. You have the larger diameter polar tubules, and the posterior tubules are of smaller diameter, which vary in number between 7 to 9. So on the right, we can see the similar picture. So to cut short the story, we have to see now what are the species that had a uninuclei or a binucleate. So when initially Dr. Rima shared that which are the species that could cause myositis, there were 4 to 5 species, and of that the Brachyula species and Tubulinosema species, they are diplokaryotic, and therefore we can easily rule out them. And the consideration now will be between the Trachyspora and the Pleostospora species. And we can see that they both of them show an uninucleate structure, and the size was almost similar to what we expect to see. And the number of spores is one of the feature. Under Trachypleostospora, the number of spores will be more in the sporophorous vesicles compared to the Pleostophora species. And we did see that on the lower magnification that there were plenty of spores. So if we look at this life cycle once again, there are 3 phases. The proliferative phase and the sporogenic phase is the one that actually happens within the host cell. And when we look at the sporogenic phase, where it actually divides and differentiates, so we see that in the sporogenic phase, the Pleostophora species, they have multiple binary divisions, and they form within a single sporophorous vesicle at least multiple sporons are seen, whereas in case of Trachypleostospora species, there will be single binary division, and there will be each of this division results in formation of individual spores. So in this, keeping all this in mind, we come to a conclusion that based on the number of polar tubes, it's around 7 to 12, and they were in a row arrangement of 7 tubules, and the posterior tubules 1 to 2 tubules. And they were all uninucleate tubules, and the size of the mature spore also falls into the range of what we see in Trachypleostospora species, and there were plenty of spores within a sporophorous vesicle. So Obviously, the ultrastructural findings, they confirm that it is a microsporidial infection, and we favor the Trachypleistosphora hominis infection in this particular case. Thank you.
Thank you, Dr. Reema and Dr. Rashmi, for that very nice presentation, particularly the electron microscopy features in such great detail. And I just want to end with a couple of sentences that I think all of us are aware that microsporidial myositis is one of the causes of infective myositis in HIV. But when we this is a very recent case that we had, and I thank Dr. From just 1 second, Dr. Jayachandran, Dr. Jayachandran from JIPMO from providing this case. We just reported it last week. But in the first case that we saw at NIMHANS, I'm afraid as pathologists, we made a mistake and called it as Candida because it was HIV and the patient had candidiasis. And subsequently, we reported a short series of 5 cases with Dr. Patel. And I just want to bring this to the awareness that microsporidial is the one that is most common rather than the others. And they respond well to albendazole. But if left untreated, then they can do badly. So that is the teaching point from this takeaway lesson from this case presentation. Thank you.
Questions on the chat. Let me ask a question on very good presentation. I think the opening batsman have used power play very well. Very nice presentation, very interesting case. How is it differently they behave, and what stage of HIV infection do they present? Is there any particular CD4 count where they present, or it can be any stage?
The CD4 count less than 100.
Okay. And any particular pattern in terms of myositis where you suspect clinically this could be a possibility?
I was just going back and looking at our previous paper. The other cases were from Pune, and only one case was from here. And they have presented it as proximal muscle weakness. So I think elevated CPK, pain, those are the features. There are no specific findings to indicate that it's parasitic, except that CD4 count is low, CPK is elevated, and it's an immunocompromised patient.
Okay.
And usually on histology, because sometimes the pathologist may not be entirely aware of this. So you can push them, nudge them towards that. Some of our previous cases had neutrophils and eosinophils. This particular one is more chronic and has more of lymphocytes and plasma cells. And this particular case was just loaded with a lot of spores in this. Thank you.
Thank you.
If I can pitch in. Hello?
Yeah.
I think from this case, what we can know is, even though clinically suggestive of inflammatory myositis in retroviral patient, I think we should do a muscle biopsy, not just do the antibodies and find out if some Jo1 or any of these antibodies are positive. It could be a false positive. Definitely, we have to look for opportunistic infections, I think. So not just doing a muscle. Right now we are going away from muscle biopsy in many of the myositis. So now I think in the inflammatory myopathy, like picture in immunocompromised, I think biopsy may be mandatory, and that's what I can gather from this, because patient didn't respond to treatment.
Oh, yes, Dr. Nadik, thank you for highlighting that point. Yes. I think once you're aware of this, you will not miss it.
Yeah, that's true, madam. That's what. Otherwise, because Jo1 positive would have given steroids, then we thought steroid myopathy, and then EMG, and then our whole thought process will go in a different way. And because these patients will be on antiretroviral medications, and then zidovudine or anything that can also cause mitochondrial dysfunction and myopathy. So we would have gone drug reduction, so many other things. I think we should have low index and looking for a biopsy in a immunocompromised patient. That's what this case highlights.
Yeah.
And also selection of the appropriate muscle too would help.
Yeah, yes, ma'am.
Thank you.
So thank you, Team Nimans. We will move on to the second case from St. John's. Now would request Dr. Shivaram Krishna to introduce the speaker, the presenter.
And the next topic is by Dr. Sucharita, postgraduate from St. John's Medical College. She is going to present to us the confused myelin. Let us see what.
Can I start, sir?
Yeah, go ahead, go ahead.
Yeah, sure.
Yes. Good evening, everyone. Today I'll be talking about a case termed confused myelin. This is a story of a 21-year-old lady who is 9 months postpartum, presented with who's a homemaker hailing from Davangere, who presented with history of fever since 15 days, headache since 15 days, unsteadiness since 7 days, blurring of vision in both the eyes since 5 days. Coming to the presenting complaints, she presented with fever since 15 days, which was present daily, lasting for 3 to 4 hours, 2 to 3 spikes per day, which was high grade, associated with chills, subsiding with medications for few hours, but never touched the baseline. There was no history suggestive of URTI, LRTI, or UTI, or vaginal discharge, or rashes, or arthralgia. At the same time, she developed headache, which was continuous, throbbing, holocranial, associated with photophobia, which was moderate to severe in intensity, affecting her daily activities. It was associated with nausea and multiple episodes of vomiting. There was no history suggestive of postural variation of the headache. 7 days into the illness, 7 days later, she developed swaying to either side, which was not associated with vertigo, loss of sensation, or dysarthria, with no variation, diurnal variation of the unsteadiness. 4 days later, she developed blurring and double vision of both the eyes, right more than the left, which was sudden in onset, and it has been progressive. Diplopia was binocular for distant objects with the images side by side. There was history of right periorbital pain 1 day prior to the onset of visual symptoms. There was no history suggestive of color desaturation. There was no history of facial deviation, swallowing difficulty, nasal regurgitation. No history of weakness of any limbs, paresthesia, bowel and bladder symptoms. No history of smearing of food or dysarthria. No history of excessive sleepiness, altered sensorium, history suggestive of seizures, or no history of joint pain, rashes, dry eyes, dry mouth was noted. There was no weight loss. There's no history of loose stools, recent travel, or dog bite. Summarizing the history with whatever we have till now, it's a young female who presented with subacute onset fever, with headache, blurring of vision, diplopia, and unsteadiness that has been progressive till now. The differential at this level that we considered was subacute meningitis, which could be of infective as well as non-infective etiology. Infective, it could be partially treated bacterial meningitis, viral or tubercular or fungal. And non-infective, it could be an inflammatory disorder like sarcoidosis or vasculitis and SLE. The other differential could have been cerebralitis. Now, going back and reviewing her past history, which was significant, 3 months ago, she had history of acute urinary retention with no history of girdle-like sensation, no history of back pain, or no history of weakness of both the lower limbs. She was diagnosed to have myelitis, and she received intravenous steroids followed by oral steroids. Complete resolution of symptoms was noted by 1 week, and she was on tapering dose of steroids for the next 2 months. But 20 days before the onset of the second episode of illness, she stopped all these medications. Her personal history revealed decreased appetite with normal bowel and bladder habits, with no history of smoking, alcohol consumption, or high-risk behavior. Her menstrual history was regular. Currently, she was lactating and she had lactational amenorrhea. There was no history of abortions in the past. Reviewing the history after the past history. So it's a subacute onset meningitis on a background of steroid-responsive myelitis that was probably a demyelinating event. The differentials, what we would consider, along with neuroinfection, systemic autoimmune disorder, and inflammatory disorder, a high possibility of relapse of demyelination is considered. We reviewed her old previous investigation records, which showed that she had the laboratory investigations, in that she had anemia, but the typing of anemia was not known. And a CSF analysis was done, which revealed CSF pleocytosis, which was mostly like lymphocyte dominant. And abdominopelvic scan was done, which revealed a post-void volume residue of 500 ml. MRI spine was done in the previous admission, that was 3 months ago, which showed that there was a T2 flare hyperintensity that was noted it was a longitudinally extensive transverse myelitis that was noted from the C2 to the C5 region, spanning almost the 3 vertebral segments, and there was no post-contrast enhancement that was noted. On the axial section, we were able to see a H sign. MRI brain was done. MRI brain revealed bilateral T2 flare hyperintensity in the ventrolateral thalamus and the internal capsules, as well as bilateral claustrum, but it was asymmetric on the right, more on the right than as compared to the left. But there was no post-contrast enhancement that was noted. There was also evidence of subcortical gray matter involvement, in that was asymmetric, more on the right frontal than the left frontal. Brainstem was not involved. Our thought process at this time was the history what she presented was suggestive of subacute meningitis with the background of demyelinating like event. Considering the MRI findings and the MRI spine findings, it was more like MOG or Adam-like presentation. The odd feature was there was involvement of the cervical spine region in MOG with the H sign, but the conus was spared. But whereas in MOG-like presentation, it is the conus that is most commonly involved. But the MRI features the fluffy subcortical white matter hyperintensities is more like MOG-like presentation. Coming to the general physical examination with this, a young female who is moderately built and nourished, conscious, cooperative, oriented to time, place, and person, with no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. There were no rashes, swelling, joint pains, or ulcers. And vitals were stable. Her temperature was 98.6 Fahrenheit at the time of admission. On CNS examination, her higher mental functions were normal. Right eye pupillary RAPD was present. Visual acuity was decreased. She was able to count fingers only at 3 meters in both the eyes. Color vision was impaired. Fundus examination was normal. Right lateral gaze palsy was seen. Convergence was impaired. Gaze evoked nystagmus was seen. Rest of the cranial nerve examination was normal. Motor system examination was normal. Reflexes were brisk with plantar being withdrawal on the right and left side it was flexor. On sensory examination, pain, touch, temperature, joint position, sense and vibration was normal. Cerebellar signs, finger nose test and heel shin test were impaired bilaterally, left more than the right, and gait was broad-based ataxic gait. There was mild terminal neck stiffness that was present with no abnormal movements. The rest of the other system examination was normal. Deficits at the end of the examinations was right eye RAPD that could have been localized to the right anterior visual pathway, diminished visual acuity and color vision localizing to the optic nerve, right lateral gaze palsy localizing to pons, brisk reflexes could suggest involvement of the corticospinal tracts, impaired finger nose test and heel shin test and ataxic gaits localizing to the cerebellum and its connection, and terminal neck stiffness showing the involvement of the meninges. After examination and with the findings of the examination, we have the differentials that were still considered were neuroinfection, demyelination, and inflammatory etiology. Demyelination was on top of the list because the localization was multifocal in this patient. Coming to the course of the course in the hospital, patient was empirically started on antibiotics and steroids after sending the routine blood investigations, and MRI brain with contrast was advised. On the same day, we obtained the laboratory investigations. Her hemoglobin was normal. Total counts, ESR and CRP was normal. LFT, RFT, and urine routine was normal. MRI brain was done. MRI brain revealed T2 flare hyperintensities in the dorsal pons as well as in the medulla. And there was involvement of the hypothalamus, the medial temporal region. Hypothalamus, corpus callosum was involved. Dorsal brainstem was involved. And there was increase on new fluffy infiltrates that we could see, which was asymmetric in the left higher parietal region with no post-contrast enhancement. MRI spine was not done due to financial constraints. Considering the history, examination, and MRI features, diagnosis of demyelination was kept on the top priority. And probable NMOSD versus MOG was considered. Further workup was done to evaluate the cause of demyelination. On day 1, after starting steroids, there was significant improvement of 50 to 60% in terms of reduction of headache, diplopia, blurring of vision, and vomiting episodes. No spike of fever was noted after the first day of admission. Total counts ESR CRP was normal. So on the second day, we did a CSF analysis to rule out neuroinfection. So here we found that she had CSF pleocytosis, but gram stain, malignant cells, and meningoencephalitis panel was negative. HIV, HBsAg, VDRL was negative. ANA immunoline was negative. ACE levels were normal. This is the report of her meningoencephalitis panel. The same day VEP was done, which showed prolonged P100 latencies of 137 on the right and 138 on the left. We also sent serum NMO-MOG that turned out to be negative. Her symptoms had improved by 90% at the end of the second day. CSF study was not suggestive of neuroinfection, hence antibiotics and antivirals were stopped. The possibilities after the second day, what we considered was demyelination. That was NMO versus MOG versus aggressive MS. As serum NMO was negative and there was evidence of dissemination in space and time, aggressive MS was also considered. Inflammatory lesions like sarcoidosis was low on the list because it was not enhancing lesions and ACE levels were normal. So on the third day, we sent oligoclonal bands, which was normal, which was negative. And we also sent CSF, NMO, and MOG that turned out to be negative. So at the end, what is the diagnosis? So it is a relapsing demyelinating disease, which is steroid responsive. But what is the cause for this demyelination? So the differentials for relapsing demyelinating disease could have been NMOSD, MOGAD, or sarcoidosis. But sarcoid was ruled out because there was no contrast enhancement and ACE levels were normal. Lymphoma, no, it could have been possible, but because it is steroid responsive, but there is no diffusion restriction and on the diffusion weighted sequence, and malignant cells were negative on CSF. So the possibilities were NMOSD and MOGAD. So diagnosis, clinically, our patient had an episode of acute myelitis followed by bilateral retrobulbar optic neuritis, area postrema, and acute brain syndrome, which was steroid responsive. MRI spine has LETM in cervical region with H sign, suggestive of MOGAD. But the odd feature is there is no conus involvement. It is the cervical involvement that is present. MRI brain has few features suggestive of MOG, like the parietal lesions that are present, and few features of NMOSD that are periventricular and hypothalamic involvement. However, both serum as well as CSF was negative for both NMO and MOG. So we reviewed the literature. So the diagnostic criteria for seronegative aquaporin NMOSD disorder or unknown aquaporin status was reviewed. So our patient fits into this criteria. That's the seronegative aquaporin NMOSD. In this, at least one core characteristic should be present, consisting of optic neuritis, LETM, or it has to be an area postrema syndrome. Our patient had LETM, our patient had retrobulbar optic neuritis, our patient had acute brainstem syndrome also. And MRI findings were also consistent with it. So coming to the treatment, what was the treatment that was given? She received injection methylprednisolone 1 gram per day for 5 days, followed by oral steroids at 1 gram per kg, 1 mg per kg per day. There was 90 to 95% improvement in her symptoms. So what are we going to do next? Close follow-up and to watch for relapse episodes and plan on immunomodulation. So what was confusing about this patient was that she presented with features suggestive of meningitis, but it was a true relapse that she had, true relapse of demyelination that she had. This is an article from the Frontiers of Immunoneurology, where there is an aqua4 positive neuromyelitis optica spectrum disorders with meningoencephalitic like onset. That was a case report that was published. In this, the presence of aseptic meningitis combined with clinical symptoms such as optic neuritis, myelitis should raise the possibility of NMOSD diagnosis. So the take-home message from this is no clinical or radiological feature can conclusively differentiate between aquaporin 4 NMOSD versus MOGAD. Close follow-up of such patients is required and aggressive treatment to prevent relapse is recommended. To consider NMOSD in patients presenting with fever and intractable vomiting, headache, and with CSF pleocytosis is essential. Thank you.
Thank you, madam. Hello.
Hello, sir.
Ah,
Yes, sir.
thank you for the nice case. Any questions?
If the chair permits, I would like to add. So here the question was the NMO antibodies are persistent, means it is low. So probable reasons what we thought was this patient had received steroids beforehand during the first episode. So once some patients receive steroids, I don't know how much it can come positive. If Dr. Anita can pitch in and they can report. So this even we did CSF, that also has come negative. So is there any role of doing CSF antibodies if the serum has come negative, especially in NMO and MOG? Is my one question. The other thing is whether it is true NMOSD, because these are all overlap syndromes. We really don't know. Is there any other antibodies like glial fibrillary? We don't have that, but that's not like classical findings, I think. But the treatment will be same, steroids, close follow-up, and consider immunomodulation. And she didn't mention, we thought we'll give her rituximab in these patients as it is more like an NMOSD, and then we have started it and then we should follow up.
Dr. Raghu, in fact, even I wanted to ask, what is the time of testing? Because like you said, if prior immunomodulation has been given, you can get a false negative MOG. Maybe that's what has happened in this case.
Yeah, that's what we also thought, ma'am. So another take-home message is that I think when we all see, it is better we take one sample and in all demyelinating disease, whether it may be a classical MS also, these are the biomarkers we have. We should send a sample so that it will help us in guidelines. There are sometimes MOG can be falsely positive in MS patient. That is also there.
Correct.
But one should be aware that if you don't do it, then next subsequent follow-ups, and we'll, because I don't know whether this patient will ever come positive now. But the clinical picture, and she has got 2 episodes, this was more catastrophic for her. So we don't have any options of withdrawing her treatment for next few years, I think at least for 2 years. So that is one more message, is that as a physicians, we should have low threshold to send NMO-MOG antibodies in these type of disorders.
Yeah, absolutely right. A lot of literature is there with plasmapheresis and IVIG, making the MOG completely disappear. I couldn't find any literature which tells you how much of steroid, if you gave, does it disappear. That I don't know. But I think this is a case in point where it has become negative, or it's truly a seronegative is now very, very difficult to say. Question on whether CSF is to be done. Answer is no, because serum, it's not intrathecal production, no?
Yes.
So you don't expect CSF to be positive. You would want the serum to show. So it's not going to help. But in the next, if she has an acute episode, peak of episode, maybe you can repeat.
That's what, ma'am. This was the peak of the episode when she had come. So we had actually first sent the serum, which came negative, then we sent the CSF. So this time she had presented, I think, first day we gave only dexamethasone with antibiotics. We were strongly thinking of neuro infection. So then the second day onwards, we started her on methylprednisolone. Once the CSF was not suggestive of neuro infection, and she made a dramatic recovery within 24 hours. She was photophobic, restless, and next day she was walking. So that is a dramatic response.
Yeah.
Interval.
Yeah, imaging.
Initiated steroid on this. Sorry, sir.
I think Dr. Sharath is there. I think he has also seen the images. So there are
imaging is, sir. Imaging is very, very classical of MOGAD there, because it's not mandatory that always CONUS should be involved in all MOGAD cases. It can mimic, it can involve any part, though CONUS is considered as one of the characteristic imaging finding. But the H-shaped central gray hyperintensity and ADEM-like mimicker, it was ADM-like picture on imaging.
with a LETM and a central gray matter involvement, no T2 bright spotty sign, no enhancement, all favors more towards MOGAD. So I would have reported as probably seronegative MOGAD as the first differential diagnosis or ADM. That's it. Imaging is very, very fitting to MOGAD.
So Raghu, interval between steroid initiation and testing is?
Actually, when steroids was given 3 months back, methamphetamine, she was on oral steroids. She was on the tapering because she had improved. And she had stopped before this episode. So it was almost, she would have taken about 8 weeks of steroids.
Then it could still be a false negative.
Yeah. And the other thing, if Dr. Sarath, you can mention that retrobulbar, it was more of a retrobulbar neuritis, and then that hypothalamic involvement with high fever. So, and that was, which, see, that's what overlap of MOGAD, NMO. So that's what, so it's a gray line. What is it really MOGAD or really NMO is the question, because the antibodies are negative in this patient.
Okay.
Can I now ask Dr. Raja to, ask a question or make a comment? He had raised his hand. Host, can you unmute Dr. Raja? So go ahead, sir. Can you unmute and ask the question, sir, or make a comment, Dr. Raja?
I don't think.
Okay. So then we'll get on with the next case. I invite Dr. Shabrish from Ramaya Medical College for his presentation. Can I have the introduction slide, please?
You can.
Yes, sir.
Stop sharing. Thank you.
Yeah, Dr. Shabrish is Associate Professor, Department of Neurosurgery at Ramaya Medical College Hospital. So he'll be presenting a case of hemispherotomy clinician's conundrum. Over to you, Dr. Shabrish.
Thank you for the introduction, sir. Is my screen visible?
Yes, please, go ahead.
Yeah. So good evening to one and all. So I've chosen this topic, which is very close to my heart. Then pretty common epilepsy surgical procedure with the decades of history, and it is still evolving, this particular field. But then when a child or an adult, especially presents with hemispheric epilepsy, we all go through this conundrum, whether we can actually do the hemispherotomy or not. So what are the possible dilemmas that one would come across, and how we can, face it, and then help the patient to have a seizure-free life. And this surgery I've chosen because this is considered as one of the crown jewel of epilepsy surgery, with the complexity of the techniques as well, and then the amazing seizure freedom rate that can be achieved with this particular technique. But with the mixture of history of bad functional outcomes, this technique is not really sought out for, and most of the time it becomes a last resort for the hemispheric epilepsy. So yeah, this is the outline of my talk today. Through a case unit, I would like to highlight the surgical safety of the procedure, and then of course the seizure outcome and the functional outcome of the procedure. So today I'll be presenting a case of 2.5-year-old child with focal drug refractory epilepsy one of the patients referred from Dr. Ann. I'm not sure if Dr. Ann is online. I guess she's traveling. So I'll be covering the clinical details and I guess video EG as well. So she's a 2.5-year-old child, boy, presented to us with focal symptomatic epilepsy with the onset around 3 to 4 weeks of life, very early onset of epilepsy, with birth history just about having maternal PIH and having been delivered through a cesarean section. A highlighting feature is that with a large head circumference of 34 centimeter. I guess that would give you all a clue as to what this diagnosis is going to be. So when child presented to us, there was a global developmental delay and is able to walk with 2-hand support from 18 months onwards. And yeah, and the handedness was, sorry, this is right side handedness, because the left side there was hemiparesis already. And there were no meaningful words yet. So semiology of the seizure. So this is the home captured video at home, where you can see the head and eye deviation to the left, trunk crouch with the noisy breathing, and left upper and lower limb tonic posturing, and the tonic cloning twitches which progress to go on to develop GTCS. I mean, the reason why we actually showing this habitual seizures was we couldn't really capture this seizure during the video EG when we had some minor events with the electrographic correlates. So this was the semiology at presentation. And this slide gives you a overall temporal profile of the evolution of the epilepsy in this child. It started with just 2 drugs and very early onset, as I said earlier, with 5 events in the first 3 to 4 weeks of life. Then progressively, drugs were added. And when the child presented to us, child was already on 4 anti-epileptics, with the EEG features still showing ongoing continuous spike in wave discharges, and hence steroids were started by Dr. Ann. So this was definitely a proven case of drug refractory epilepsy, considering the definitions of 2 years and multiple drugs. So on examination, there were no major neurocutaneous stigmata seen, with no dysmorphism except for the skull asymmetry, where the right side was bigger than the left. So, and other than that, on examination, obviously there is a small left eye esotropia, and then there's obvious left hemiparesis with around grade 3. The best power that we could see was grade 3 weakness with significant hand weakness on the left side. Child also had dystonic movements and other upper motor neuron signs. So this is the video EG. I'm not sure Dr. Ann is online. Okay, this is basically the
I'm here.
Yeah, madam. Yeah. So this is the interictal record. Madam, you want to comment on that?
Interictal. This is the first one, isn't it?
Yeah, this is interictal. I'll just rush through the pages.
Yeah, there's increasing fast activity on one side, isn't it?
Yeah. On the right hemisphere, we had
right hemisphere
we have,
and it's beating more. It's increasingly building up, isn't it? And we had to reduce the drugs, and then we got this. And
these are all interictal discharges from the right hemisphere. I'll go to the
and there is asymmetry. There is background asymmetry as well, which you can see with change in frequency as well.
Yeah.
Of the.
So this is the first event. You can see that mild movement that happened on the left upper limb and lower limb. Child were on steroids and then multiple anti-epileptics. What we can see is that right hemisphere classical spike discharges from mostly from the frontal and the parasagittal leads, but entirely right hemispheric. So the left hemisphere was clean. And this is another event. Again, the left upper limb jerks. Again, showing right hemispheric discharges, mostly frontal and parasagittal leads. Yeah. That's it. So these are all the video EEG findings. Unfortunately, we couldn't record the habitual seizures. And this is the MRI. So as you all can see, that's very obvious features suggestive of the right hemimegalencephaly, where you can see the extensive dysplastic hemisphere with a lot of subcortical heterotopias and with a lot of periventricular gliosis. And you can see here, that is a very bad feature with the hypertrophic septum pellucidum, which is significantly, which poses difficulties during the surgeries where we had to enter the ventricles to disconnect the hemisphere. This is again the sagittal view of the same FLAIR MRI, where you all can see the entire hemisphere is abnormal, with subcortical heterotopias and significant dysplastic features in the cortex with sulci and chiral abnormalities. So considering the AEC hypothesis, our workhorse, entire clinico-radiological pictures and electrophysiological features were suggestive of right hemispheric pathology. So, and since the entire hemisphere were involved, we decided for right hemispherotomy. So the pre-op evaluation was normal except for hypothyroidism, for which child was already on replacements. And the significant feature that I would like to highlight is that we did subject this child for a preoperative rehabilitation, the popular pre-rehab strategy, for almost 6 months before the surgery. So the surgery which we performed was the right vertical parasagittal hemispherotomy using the interhemispheric approach. So the reason why I'm highlighting is that there are many centers still following the perisylvian technique of hemispherotomy, which is equally efficient and with the good outcomes. So we followed this particular technique. And that is the post-operative CT. And one can see in the axials, the clear anterior disconnection and the middle disconnection, and of course, the posterior disconnections. Broadly, 3 steps of the surgery. And for the completion, one can see that disconnection line in the middle disconnection extending from the lateral ventricle, body of the lateral ventricle, extending down to the temporal horn of the lateral ventricle, which indicates a complete disconnection. And then, of course, the major part of the surgery would be the total callosotomy from anterior to posterior, extending from the genium to splenium, which is very significant to avoid recurrence of seizures in hemispherotomies. So as a first step, I failed to, I forgot to mention that we did take biopsy wherever we did the exposure for during the interhemispheric approach, where the superior frontal gyrus was excised and sent for biopsy. So that came as actually the reactive astrocytosis with gliosis. There was no features of cortical dysplasia. Maybe the sample. Sorry. Yeah. So obviously the site was not representative probably, but maybe if we had gone anterior or posterior, probably would have got the cortical dysplasia as the biopsy result. And the major highlight that I would like you all to notice is the amazing improvement in the left upper and lower limb movements within 2 months of the surgery. A child is definitely seizure free. I mean, it's too early to comment on the seizure freedom. The minimum time period that we would usually use is at least 2 years. But then with 2 months of follow-up, the functional outcome with complete disconnection is what I would want to highlight for today's presentation. So that's about the seizure freedom and the functional outcome of this particular child. So coming to the second part of the talk as to how and what are the techniques that have come to enhance the existing surgical safety. Today, we do use navigation and very sophisticated microscopes to do the vertical hemispherotomies. But then the one step ahead, we can use endoscopic assisted techniques to do the same hemispherotomy with a much smaller craniotomy and much smaller exposure. And this is the paper which we published giving the seizure freedom rates and functional outcome rates. So, and one step ahead is the bloodless technique, which we recently published in JNS Pediatrics, where thermocoagulation was used. Of course, it was robotic assisted thermocoagulation, where it is this is what do you say? It's a complete bloodless technique, because obviously the middle disconnection, which goes through the basal ganglia, is one of the most vascular step of the surgery. And the entire surgery that I did now with the vertical hemispherotomy, which went on for around 6.5 to 7 hours of surgery. Obviously, we do replace the blood and all that, but then, if possible, if the the patient's brain anatomy is supportive, one can definitely use this advanced technique of thermocoagulative hemispherotomy. Of course, these are all the infrastructure-driven techniques. So, nevertheless, I guess one would, if one would want to improve their seizure outcome rates, first to begin with the patient selection. If the patient selection is good, and still if the seizures have recurred, then definitely we need to look into the the disconnection aspects, where we analyzed our series of cases at AIMS, and we found out that the temporal stem was one of the critical site. And this holds good for any other techniques. For example, perisylvian technique, the frontobasal disconnection was one of the the Achilles point for remnant connections. So if the patient selection is good, I guess definitely one should look into the disconnection parts of it and see if there's any remnant disconnection. And the DTI imaging is very useful in such cases, where even the Dr. Sanjeev, if you can mute the microphone, that will be helpful. Thank you. So temporal stem is the in our series with vertical hemispherotomy, temporal stem was the site of remnant connections. And when we went back and we achieved close to 95% of seizure freedom rate, which is very good as compared to any other techniques in epilepsy surgery. So coming to the aspect of enhancing the functional outcome. So we analyzed our cases with the preoperative fMRIs, which is very, very useful. I guess when a patient with hemispheric epilepsy do present to a clinician, one would always think, by doing a hemispherotomy, are they going to be permanently hemiplegic? So that is not the case if the age of onset of weakness is before 7 years, or to max in the literature is around 10 years. So not more than that. And more than that, the plasticity rates are going to be variable. And of course, here is in this study, we analyzed the left hemispherotomy, supposedly a dominant left hemisphere, which undergoes perinatal ischemic infarcts and becomes gliotic and goes on to develop drug refractory epilepsy. Even in those children, we have seen that the entire right hemisphere taking up the function of the speech and the motor functions. So the right hemisphere compensates for the loss and they remain functionally intact. So we analyzed the age cutoff for this plasticity to happen, and we could arrive at the number of around 7 to 8 years. So any children who acquire these deficits before 7 years of age, the right hemisphere would definitely take up the functions, and they go on to lead a normal life. They will be ambulant, but the remnant deficits are always seen in the hand. Hand is something which doesn't recover with irrespective of what rehabilitation procedures have been taken care of. So the and whether to use fMRI or not, whether to go ahead with just the clinical picture at presentation, because many would say that yes, if the onset of weakness is pretty early, then one can actually proceed without these kind of functional imaging. But then many papers, including one by Arthur Kuke, where there's a largest series of hemispherotomies, that even they reported, in spite of developing the weakness at around 4 to 5 years of age, those children did develop a significant deficit following hemispherotomy, and they did develop residual weakness. So the plasticity is very much variable. So I guess if fMRI is possible, if the child is cooperative, I guess more than 4 years or 5 years, they will be cooperative enough to do a functional imaging. And the highlight is that even if an adult presents with a hemispheric epilepsy, one can definitely go ahead with hemispherotomy if the age of onset of weakness is below 7 years, and if the fMRI shows the transfer of function has already taken place to the right hemisphere. So that would be the take-home message, I would say. So definitely, if you can see, this was one of the adults that we followed up, and she had undergone hemispherotomy at the age of 21 years. The age of onset of weakness in her was around 2 years, and following them, and you can see in the MRI that there is absolutely no hemisphere existing. It was totally gliotic, and hemispherotomy was a very simple technique with disconnection of few cortical mantle to the central core of brain. So once we disconnected, she became seizure free, and on follow up, she became she was free of drugs as well. So reasonably good functional outcome with just single functional hemisphere. So I guess we can give them a good functional outcome and seizure freedom rate. So that's the take home message. Thank you all for the kind attention.
Nice presentation, Dr. Shabri. Anyone has any questions? Dr. Shabri, do you consider this as a palliative procedure, or is there any other alternative where you can further localize and do any radiofrequency ablation in certain areas where the seizure is coming from? Even though the whole hemisphere is involved, but you can have areas where specifically you can have discharges coming from.
Yeah, so that's a great question. I mean, this is sort of a bargain that we always do. And what we actually look for in a video EEG is that, are there any discharges with anterior pole and the posterior pole? For example, if the frontal lobe is involved and the occipital lobe, and definitely those kind of, the functional sparing hemispherotomies are possible, definitely. But then seizure freedom rate is always questionable when we do try to save the hemisphere. For example, hemimegalencephaly, Rasmussen encephalitis, and all those children, definitely the whole of hemisphere will be usually involved. So it depends on the pathology. If it's a cortical dysplasia limited to one particular lobe, or where we can spare the sensory motor cortex, maybe yes, definitely, as you said, we can give them. We will try to save the eloquent cortex as much as possible. Yeah. Yes, madam.
Just a point to note. Sorry, pediatric neurologist here. And for us, as a physician, as a non-surgeon, the main important point for us here was that we were unable to localize. It was more than two lobes, isn't it? I mean, 2 parts. It was not just one hemisphere agreed, but more than 2 lobes. But the point to make here is, at presentation, when we were considering surgery for a drug refractory child, this child had no verbal output, had no expressive speech. Receptive speech was also very, very, absolutely nothing there. 2 weeks after surgery, when we saw this child for the first time, he was actually having receptive speech. He has already started showing improvement with regards to developmental milestones. So the whole purpose of going into this was because this was a young child, to try and prevent mental retardation, for inflicting such a major surgery on this child. That was the point. And the parents were very convinced of that. And they've themselves said that, he's picking up cues. So we are showing the deficit we have inflicted, which is a motorical defect, which is a hemiparesis. And the hemiparesis we are, getting back, and we will never get it back to perfection. But a dorsiflexion in the hand probably seems like a decent trade-off for us from the background as people taking care of children, in that he might be able to lead a somewhat normal life, because he's beginning to pick up language and intelligence being so closely correlated. Dr. Shabri, would you agree with that?
Yes, absolutely. I totally agree. I guess we are trying to look at saving the other hemisphere as soon as possible. When the entire hemisphere is involved by the pathology, definitely, I think this is more to do with the patient selection. If the candidate is for hemispherotomy, then nothing should stop us from, venturing into it. That was the whole idea of today's presentation, that we should not take a step back and say, okay, let's, save and see. I mean, there are n number of literature I can quote that anything less than hemispherotomy in cases like these will fail, and they will come back with recurrence. And we are going to lose that important, crucial time period where the child is developing the very important milestones. So I guess once the candidate is the right candidate for hemispherotomy, we can definitely go ahead and do it, I guess. Yeah.
Great, thank you. If there are no other questions, then yeah, Dr. Anita, yeah.
Dr. Shabri,
yeah,
very nice case. Hi.
Thank you.
Just a pathologist perspective, like you showed in this particular case, I think the pathology didn't show the lesional tissue. So in most of these disconnection surgeries, particularly hemispherotomies, just a gentle request that when you submit tissues, make sure it's lesional. And if you're not hitting the lesional tissue, I think it's equally important to tell us that this is non-lesional. Otherwise, we keep digging, hoping to find some.
Yeah, I mean, I wanted to touch upon that point. We expose the cortex. I mean, it's a very limited exposure, middle third of the cortex, and mostly it is superior frontal gyrus. So looking at the MRI, actually, we thought we would, we are hitting the lesion. And at that point of time, a frozen section for such cases, at least at our center, we have failed. So, and then we were doubly sure that this is dysplastic. But then, yeah, it was actually a gliotic tissue. Yes, maybe we will be sending more samples next time, I guess. Yeah. Thank you for the feedback.
And yes, don't do a frozen section. No center can give you a diagnosis.
Yeah, exactly.
Please, you're frozen.
Yeah.
Thank you. Very nice.
Thank you.
Yeah, so we'll proceed on to the last presentation of today's webinar. I will now request Dr. Sharath to introduce the speaker, presenter.
Yeah, it's a great pleasure for me to introduce my colleague, Dr. Major Savit Kumar. He's a consultant intervention neuroradiologist at Apollo Hospitals, Bangalore. He completed his MBBS from KIMS Bangalore and joined Indian Armed Forces for Short Service Commission, following which he did his MD Radiology from INHS Ashwini, Mumbai, and DM from Sri Chitra Tirunal Institute of Medical Science and Technology, Trivandrum. He has many publications and contributions to the textbook chapters. Today is presenting, showing us few cases of craniospinal dural AVF, which we all know is an elusive disorder and often mimic many other conditions, both clinically as well as radiologically. So I request Dr. Savik to share his screen and show us few interesting cases and leave us some take-home messages from here. Thank you.
Yeah, good evening all.
Yeah, please proceed.
Yeah, is my screen seen?
Yeah, it's visible. You can continue.
Yeah. So good evening all. So today I'll be showing a few cases of dural arteriovenous fistula, both intracranial and spinal. I've acknowledgements to the Dr. Sharath and Dr. Satyanarayana, from whom I have collected few of the cases. So coming to the first case, a 40-year-old male, a chronic smoker and alcoholic, presented with complaints of recurrent headache since 9 years with visual disturbance. I'll show the series of MRs over the period, and then memory impairment, which was the duration of onset was 1 month. There was no focal neurological deficit. So this is at the initial presentation, 2012. No parenchymal changes or white matter changes in the on diffusion or flare, neither on T2, but we see a few flow voids which is seen in the region of the left anterior or middle cranial fossa. Nothing was done. So this is 2014 again. a subtle two white matter hyperintensities focal seen in the right frontal lobe, whereas the rest of the brain parenchyma appears normal. The phleboids again noted, they appear a little bigger now. Now, this is a time when he presented with memory impairment. Now, here we see more few discrete and confluent white matter hyperintensities, which is also showing diffusion changes, which is predominantly involving the region of the cingulate gyrus, the corpus callosum, and the periventricular region. There is no hemorrhage or bleed within the brain parenchyma. On MR angiogram, we see a few cluster of vessels, which is seen in the middle cranial fossa on the left side. Now, angiogram. So on an angiogram, what we see is this is an angiogram from the left external carotid artery. These are the external carotid artery branches, the middle meningeal artery, the accessory meningeal artery, which is forming a fistulous communication along the left convexity with which is draining directly into the cortical veins. The cortical veins are in turn refluxing to the superior sagittal sinus. This is a vein of Labbé which is refluxing to the transverse sinus, the sigmoid, and the jugular. So what we have is a dural arteriovenous fistula, which is a fistulous communication between the dural branches of the external carotid artery with the directly with the cortical vein, with reflux to the cortical veins, the superior sagittal sinus. Also the reflux is also seen to the straight sinus and the deep system. This is just to illustrate the draining vein, the fistulous point. There is a fistulous point and the feeding artery. Now, post-embolization. So post-embolization, at 2 weeks clinical follow-up, patient had a significant improvement in his cognitive function. So these white matter changes, which develop progressively over a period of time, is mainly because of the venous congestion happening due to the arterialization of the flow in the draining veins of the brain. A second case, so 50-year-old male with history of CVT 3 years ago and was on anticoagulants, presented with worsening headache for the past 1 year. Later, there was progressive memory impairment and rigidity in all limbs, and he would not follow any commands. He was unable to speak, and swallowing was difficult. It's just a video showing the patient prior to the intervention. He does not obey any commands.
చేతులు చాపండి, పళ్ళు చూపించండి, పళ్ళు చూపించండి, నాలుగు బయట పెట్టండి. ఏమైందమ్మా?
So this is the MRI. Now what we see is hyperintensity, which is seen involving in the brainstem, predominantly the pons, which is seen hyperintensity on diffusion, flare, and T2. There's also hyperintensity which is seen predominantly in the left cerebral hemisphere, involving the subcortical and periventricular white matter. White matter hyperintensity also seen in the right cerebral hemisphere, predominantly in the periventricular region. So these changes are seen on diffusion, flare, and on T2 weighted images. When we look at the SWI images, we see very prominent transmedullary veins seen in bilateral cerebral hemispheres, slightly more prominent on the left as compared to the right side. Similar prominent veins are also seen in the posterior cranial fossa. Now, if we look at the venogram, the flow signal of the superior sagittal sinus is not well visualized. Very prominent transmedullary veins are seen on the venogram. So this is the angiographic images. So this is a left external carotid artery angiogram showing the so this is the fistulous point, which is fed by the dural branch of the external carotid artery, the occipital and the middle meningeal, with reflux into the transverse sinus, sigmoid sinus and the torcular and the suprasagittal sinus. Now, if you see, there is also reflex into the through the vein of Labbé to the superficial cortical veins, and then in turn reflexing into the suprasagittal sinus. So this is a vertebral artery angiogram. Supply also from the posterior branch of the vertebral artery seen. So again, a case of dural arteriovenous fistula. So if you look at the intercarotid artery angiograms, there is significant slowing of the circulation time, and the superior sagittal sinus is not involved in the drainage of the brain, but instead the brain is draining through transmedullary veins and down to the pterygoid plexus and then into the deep system, with significant slowing of the circulation time. So embolization, transarterial embolization through the external carotid artery feed is done. So this is a squid cast showing the occlusion of the fistula and the draining vein and the proximal feeding artery. So post-embolization angiogram, complete exclusion of the fistula. The external carotid angiogram now does not show any reflux into the intracranial cortical veins and venous sinuses. So this is the MRI 8 weeks post-treatment. There is near complete reversal of diffusion changes, complete reversal of the diffusion changes, and near complete reversal of the changes on flare. And it's a near complete diffusion, near normal appearing diffusion weighted images, both in the supratentorial and the infratentorial brain. When you look at the SWA again, there is significant reduction in the prominent transmedullary veins which are seen in both cerebral hemispheres. And this is a clinical follow-up with near complete recovery.
మీ పేరండి? ఏ ఊరు మీది? Okay.
So again, the previous case illustrating the significant response on the congestive features in the brain secondary to treatment of the fistula. Another case illustration is a 68-year-old male who presented with cerebellar signs and ataxia. So on flare, we see white matter lesion, which is predominantly involving the cerebellum on the right side and the vermis. There is mass effect, which is seen in the form of effacement of the fovea and partial effacement of the ventricle. These are SWA images. Few microbleeds and phlovoids are seen within the lesion and around the lesion. And this is a post-contrast image. We see patchy enhancement predominantly along the periphery of the lesion, with prominent phlovoids along the periphery of the lesion. Now, this was presumed to be a space-occupying lesion, and patient was taken up for a biopsy, which was inconclusive. The finding which suggested that this is not a space-occupying lesion on a review of the images were the presence of this prominent phlovoids, both on the post-contrast images and on the SWA. So angiogram was done. So this is a angiogram through a microcatheter placed in the posterior branch of the vertebral artery, showing the presence of the fistula and the posterior cranial fossa. So this is the feeding artery, this is the fistulous point, and this is a draining vein. So this is the draining vein. So again, a case of dural arteriovenous fistula. This is post-embolization showing complete exclusion of the fistula. Case 4, an elderly male who presented with slow response, slow speech, disorientation, and poor short-term memory. Now, if you look at the MRI, these are SWA images showing superficial hemosidrosis in the posterior cranial fossa predominantly along the cerebellar foliae. And also we see microbleeds and focal hemosiderin staining in bilateral thalami. And also similar microbleeds are seen in the cerebellum. And also what we see is multiple bright areas which are vessels which are seen within the posterior fossa. Now, when we look at the MR venogram images, we see multiple cluster of vessels which are seen in the posterior cranial fossa, again suggesting a vascular malformation or a dural arteriovenous fistula. Now, here the patient's presentation is like a thalamic dementia. So this is an angiogram. So this is the external carotid artery angiogram showing the fistulous point between the external carotid artery and the intracranial vessels, so intracranial veins. So this is a occipital branch, transarterial. This is a middle meningeal branch. This is a fistulous point, and then in turn draining into the posterior cranial fossa cortical veins, and then refluxing into the intercerebral vein of Galen, and opacification of the reflux into the straight sinus. So here the fistula is along the convexity fed by the external carotid artery branch with predominant venous drainage into the posterior cranial fossa veins. This is post-embolization showing the squid cast. So the patient had a significant recovery of symptoms post-embolization. Case 5, a 69-year-old male who presented with a history of progressive weakness of the lower limbs for 6 months, numbness in bilateral lower limbs since 3 months. He had also bowel and bladder symptoms. So T2 weighted images of the spine shows longitudinally extensive transverse myelitis with this T2 hyperintensity with cord swelling seen extending, involving the lower dorsal, involving the dorsal spinal cord, dorsal cord and the conus medullaris with multiple flow voids. Now, on contrast administration, there's intense enhancement which is seen within the conus medullaris. Again, an angiogram shows there's a dural arteriovenous fistula with 2 feeders, one present at L1 level and other one present at D12 level. So both feeders were selectively embolized and selectively cannulated and embolized. So this is a post-embolization angiogram of each feeder showing complete exclusion of the fistula. So this is a 6-month follow-up MRI, shows complete resolution of T2 hyperintensity involving the spinal cord and disappearance of all the prominent flow voids seen on MRI. So to conclude, dementia is one of the rarer clinical presentation of intracranial DAVFs. It could be cortical or thalamic, which is determined by what is the predominant venous drainage. If the fistulous drainage is refluxing into the cortical veins, the superficial or the deep cortical veins, they tend to present with cortical dementia. Whereas if the reflux is to the deep system, that is a vein of Galen or intercerebral veins, then there is thalamic congestion, and these patients present with thalamic dementia. These cases typically present with white matter changes on imaging, which should be in the periventricular or subcortical white matter in cortical dementia, or in the deep gray matter as in thalamic dementia. These changes are secondary to venous hypertension. This venous hypertension is caused by fistulous communication between the artery and vein and arterialization of the vein. And patients, when persistent or untreated, may also progress to develop hydrocephalus, which is again because of the impaired CSF absorption due to arterialization of these veins. So these white matter lesions, either in the brain or spinal cord, in a intracranial or spinal DAVFs, can show enhancement. That is because of the disruption of the blood-brain or blood-spinal cord barrier, which could easily mimic a tumor if DAVF is not suspected. So always have a low threshold to diagnose a DAVF, especially when you see flow voids in an abnormal location in the intracranial or in the spinal cord, because these are completely reversible conditions if treated on time. And also a wrong diagnosis of a spinal transverse myelitis, longitudinal extensive transverse myelitis as a demyelinating condition, which generally tend to be treated with steroids or as a part of workup, a lumbar puncture is done, will cause a significant progression of symptoms in patients with spinal DAVF. So having a low threshold, picking up the subtle finding of flow voids in the spinal cord or brain is very important to pick these conditions and treat early, as these are completely reversible. Thank you.
Thank you. Thank you, Dr. Savit. Any questions?
Sharath and Savit, most of the things were picked up on SWI. So I think how much is the significance of, because some of the images come without SWI. So I think, it may be missed if it is all the sequence are not done. So how significant is the SWI images sequence in this?
Sir, in any brain imaging, the three important sequences which should always be done is diffusion, flare, and SWI, because these are very much important to pick up any of your conditions if you have to limit your sequences. Now, coming to dural arteriovenous fistula, there are few sequences which will help you to make the diagnosis on MR imaging with near 100% confidence. That is, one is an SWI and second is an arterial spin labeling, that is an ASL sequence. Now, these sequences can pick up the presence of a fistula and the arterialization of the vein based on the signal intensity or the color pattern on the images. So SWI and ASL, SWI is definitely an integral part of any brain imaging, and SWI ASL can help pick up a dural arteriovenous fistula of the brain with near 100% of confidence.
And even in spine, if you're seeing LETM, better to get a heavily titivated images like CIS3D, which are very, very sensitive in picking up the subtle flow voids which are on the surface of the card. So SWI, even if you are doing a screening because of limitations, please request to do a SWI sequence in the brain, and typical elderly male with a progressive paraparesis, all those cases, better to get a heavily titivated images in the spine so that most of the lesions are picked up at the appropriate time and treatment can be initiated. Once the bladder and bowel gets involved in a spinal dural AVF, probably the treatment effect and the cure rate is very, very less. So that's the message. Have a low threshold, ask for DSA if there is any subtle suspicion so that this can be treated as early as possible.
Right.
In the spinal DAVF, especially, the reversal of the symptoms post-treatment is always not complete. Means the motor symptoms are the ones which tend to reverse to the maximum, whereas the bowel and bladder symptoms may not reverse at all, and the sensory symptom reverse to a lesser extent. So timing of treatment is very important, because if we pick up the condition very early and treat him, we may be able to reverse all his symptoms. But if we treat him late, we may reach a stage where reversal is only partial.
Good, thank you. So if there are no questions now, I would like to conclude the session. So I would have to request Dr. Anita and Dr. Shivaram to make their concluding remarks.
I think fantastic session, great cases that were presented, a lot of learning. I think it's a fantastic start, and let's hope every webinar has more and more attendees. I noticed that I think we started with almost 30, 38, and the numbers I think remained almost the same till the end. So
went up to 42. Went up to 42.
It did? Okay.
Okay. It was a nice session. We had very interesting cases and good discussion. We hope we will continue with the same spirit in the coming months. I request all the members from the different places also to contribute and make the series interesting and fruitful.
So thank you all. I would like to thank all the speakers from NIMANS, from St. John's, Ramaya Medical College, and Apollo Hospitals, both the presenters and the mentors for presenting the interesting cases. But as I said, it was very interesting, all different aspects of neurology and neurosurgery and neuroradiology. Before concluding, I want to thank Alchem Laboratories for providing this platform, Zoom platform, which they have provided for the entire year for the academic activities. I would like to thank Lauren Farmer for supporting us for this today's academic session. We have a calendar ready for next 1 year. So next month, August, Mysore and Hassan team will present their cases. So we have adequate time to group together and present. So we want everyone, every specialty like neurology, neurosurgery, and allied sciences to present cases as much as possible and encourage youngsters to present. That's the motto. So thank you once again, everyone. Good night.